Hi, I'm Marianne Smith, and today we're going to talk about age-friendly healthcare and systems, focusing on mentation and the topic of dementia. So our goals for today are to talk just a bit about dementia, why it's important in the 4Ms, then briefly review both screening and interventions. I'd like to acknowledge that this program is one in a series of 8 programs about the 4Ms and is co-sponsored by the Somé Center for Gerontological Excellence and the Geriatric Workforce Enhancement Program at the University of Iowa Geriatric Education Center. The content's based on age-friendly initiative of the John A. Hartford Foundation and the Institute for Healthcare Improvement. We really hope that everyone will access the link below and join the social movement at your workplace. So today we're going to focus on mentation, and as we talked about in the overview program, there are 3 parts to mentation: dementia, depression, and delirium. In acute care, there's a greater focus on delirium. In ambulatory care, there's a greater focus on depression and dementia. And in senior living, we need to pay attention to all 3: dementia, delirium, and depression. So the focus today on dementia is really important, and it is critically important because the 4Ms spin on what matters most. So cognitive status is really important to having conversations about what matters. And it's really important for us to remember that having memory deficits doesn't rule out making decisions about what matters. Instead, we need to stop and consider how cognitive status does, or maybe does not, impact the person's ability to engage in meaningful conversation about their goals and preferences. So just in a really brief kind of nutshell view of dementia, let's all remember that dementia is a permanent loss of cognitive ability caused by damage to brain cells. It is not a normal part of aging. Not all older adults are impacted by dementia. It's common, but it's not normal. It is the common end result of many different entities, as listed on the slide. There are some common features, though, that I think that we can be alert to in terms of impairments in thinking, ability to reason, using judgment, including social judgment, kind of the what's right or wrong to do in a situation, solving problems, ability to use language, finding the right word for the right situation, memory, perception, and impulse control. There are also a lot of different types of dementia, although a lot of focus has been on Alzheimer's disease, and indeed, it is the most common type. There are other versions of dementia that have slightly different presentations. So it's important to remember that while Alzheimer's disease is dementia, not all dementia is Alzheimer's type. There's a vascular dementia, frontotemporal, Lewy body disease, dementias that result from traumatic brain injury, HIV, and on down the list. And I would like to emphasize again substance and medication use as a cause of dementia. We also know that dementia tends to be progressive. Now, there are situations with, for example, traumatic brain injury, where the person loses capacity rapidly and then it stays fairly stable. But most other types of dementia progress from early to confused and then later into the disease with increasing disability along the course. And in a course of dementia can be anything from 2 years to 20 years. So there's a lot of variability. In terms of common features, again, the progressive loss of ability really shows up in the person's personality, in their behavior, their emotional responses, and clearly in their functional ability, both their social function, meaning how they get along with other people, and in their physical function, thinking about how do they engage in self-care activities. So dementia really does interfere with doing what matters most. That means that identification is essential to providing quality care and living for those who have dementia. There are two main actions in age-friendly health systems and care. The first is to stop and assess, and the second is to then act on our findings. So in terms of dementia, we want to think about risk factors and presentation. We want to think about history related to cognitive function. Is there a diagnosis already in the record? And then we want to screen for dementia. Then using that information, after we're done gathering the information and assessing the person, and this does not need to be long and complicated. It's more understanding where we are with the individual in the moment so that we can make additional plans. We want to act on our findings. So we might refer the person for evaluation. We clearly want to help them manage any symptoms that they're having. And we also want to engage in helping them find additional resources and supports to be as successful as possible. When we're thinking about assessing the person with dementia, I think it's really good to normalize the screening, no matter what screening we use, by telling the person, I'm going to assess your cognitive health, just like we check your blood pressure or your heart or your lungs. I think it's also important for providers to remember that cognitive screening is indeed part of Welcome to Medicare and the Medicare annual wellness visit. Some additional tips when we're thinking about assessing is to emphasize the older person's strengths. What can they still do, not just the deficits, and to document and share findings with the team. Consider and rule out delirium, which is an acute confusion if cognitive change is sudden, meaning over days or weeks, as opposed to that more progressive decline that we showed in the diagram earlier. So in terms of this acute confusion or delirium, that is another one of the D's in mentation, along with depression and dementia. And it's important to remember that delirium can stand alone, meaning it affects the older person without there being any kind of background cognitive decline or dementia. It's also important to remember that people who have dementia can have an overlapping delirium, meaning that they have some stable features where their cognitive function is not the greatest, and then they rapidly become more confused, disoriented, have problems with attention, and are really struggling to function. That could be an overlapping delirium. So it's important to think about both. In terms of assessing people with dementia, there are lots of really great brief tools to screen for dementia in today's world. The Minicog, SLUMS, MOCA, and 6-item screener. I'm going to talk about each. And what I would ask you to remember is that we're not going to teach you how to use the tools. We're going to just talk about them and create an awareness of what is available. And then we would ask that you think about which tool fits best in your setting or practice. So to start, there's a Minicog, which is 3-item recall and a clock drawing, and is scored from 0 to 5. Now, it is just that, a screening tool. So if we get a score of 0 to 2, there is a real concern for cognitive function, which means we ought to go on and do a more in-depth assessment. The point is that it's short and it's easy to do, and that makes it really practical for a lot of people. The SLUMS, or the St. Louis University Mental Status Exam, is longer. It's 30 items. And as you can see, it also has a clock drawing, and it also has a 5-item recall. But it's also got other features that make it a more in-depth examination of cognitive function. And in that context, it makes it easier for us to gauge how much at risk the person is for having a dementia. As you can see on the slide, there a score of 27 to 30 suggests normal function, 21 to 26 mild disorder, and then 1 to 20 dementia. The Montreal Cognitive Assessment Tool, or MoCA, is a little bit like the SLUMS in terms of a score from 0 to 30 and a more in-depth examination of the person's cognitive function. And as you can see on the slide, it includes visual, spatial, and executive function, naming, memory, attention, language, abstraction. These are all very important features. And in turn, then, we can use the MoCA score to give us a better idea of where the person actually is related to cognitive impairment. The 6-item screener is another really brief screening tool, a little bit like the mini-cog. And the beauty of the 6-item screener is that it can be done over the phone. You don't actually have to be right there with the person because it's recalling 3 items and then doing some orientation questions. Again, like the mini-cog, it's designed as a brief screener that then requires additional assessment. So after we screen the person with that we are concerned about, the older adult, and to have a better understanding of what their cognitive function actually is, we want to take action. And taking action is guided by the care setting, the stage of dementia, and the identified needs of the person, as outlined on the slide. So a good starting point when we're thinking about acting on is that not all cognitive impairment is dementia. Indeed, further evaluation and diagnosis is really critical. We can overlook delirium that persists and think it's dementia when it's really not. So very important for us to think about medication side effects, another M in our 4 M's, depression, another feature of mentation in the 4 M's that can actually impact concentration and look like memory impairment, and then again, delirium that really does mimic dementia. So when we're thinking about what matters most, life and living, our ongoing health, the health care that we receive, it's really critical that we understand the cognitive capacity where the person is with their cognition in order to support them to do what matters most. So asking that question, what matters most to the person, we want to use their priorities in communicating, decision-making, and planning. And we'll want to consider, how does the person's cognitive status influence reaching his or her goals? What kind of support, assistance, or resources might be needed to reach those goals? And equally important, who else might need to be involved? But the point that I cannot say enough about is that the conversation should always start with the person living with dementia. Those who have cognitive decline should definitely be engaged in all discussions. The capacity to make many, many decisions endures in spite of having some cognitive decline, and truly clear into the middle and later stages of dementia, depending on what the question is. So I think that it's critically important that we ask about their care and treatment preferences, and we focus on their abilities. What can they still do? Granted, family involvement regarding goals of care is really important, but a person-first approach is truly the best. So in acting on, we also want to help maximize function for the older person to do what matters most to them. So we want to pause and evaluate medications and think about how side effects and drug-drug interactions might impact on their function. We want to help them maintain their mobility, help them to be engaged in activity, to walk, to ambulate, to exercise, because truly mobility is often essential to doing what matters most. And finally, we want to encourage and support their independence to the full extent possible. Through all of this, it's important to emphasize the person, not the diagnosis. We want to think about preserved ability, not losses, their individual tastes, their interests, their values, their preferences for care and treatment. We want to support them to engage in meaningful activity, what matters most. And in so doing, we can compensate for lost abilities by supporting and encourage them, by helping them simplify and adapt tasks so that they can, in fact, be successful. In terms of acting on, there are just a ton of really great online resources that offer education and support for the person living with dementia and also for their family care partners. As listed on this slide, there are some really excellent resources available. And again, depending on your role in the situation, you may want to explore some of these and share them with the person for whom you're providing care. The other big social movement that really interacts with age-friendly health systems is dementia-friendly communities. It really overlaps really nicely with being age-friendly. So being dementia-friendly and age-friendly have a lot in common, and I truly hope that you will visit the link to Dementia Friendly America to learn some more about that. Dementia-friendly communities also includes being a dementia friend, which is a program that emerged out of the United Kingdom and is a super easy and nice way to learn about friendly approaches to persons with dementia without necessarily being an expert. How can you communicate? How can you interact? How can you support? Short videos, really a truly easy and nice way to learn a little bit and without a lot of effort. So in summary, dementia is an important topic when we think about what matters most to the person and how can we guide care decisions to reflect what is really most important. So to do that, we have to recognize cognitive declines and impairment, and we apply screening tools to better gauge where the person is, discuss our findings with our team members, refer for further evaluation, think about interactions between all 4 M's, because truly in dementia, it's not just mentation or dementia. It's the impact of dementia with delirium and also depression under mentation, and then what that relates to and how that impacts their mobility, how their medications can negatively influence their function, and all of that returns to the question of doing what matters most. So if we're going to support the person with cognitive decline to do what matters most, think about not just dementia, but all 4 M's. Thanks so much.